Well, good afternoon, everyone. Can you hear me? Yeah, great. Well, first, I'd like to thank the sponsors of this initiative, Anthos, Bayer, and J&J BMS. So thank you for your support for this educational initiative, and this is the kickoff of what we expect to see as a progressive introduction into the Factor XI space. So I'm going to talk about the promise of Factor XI, Factor XIa inhibition, with the idea that this has the potential to uncouple thrombosis and hemostasis and provide us with safer anticoagulation therapy. You can use this to translate this presentation into your language of choice. What we're going to do this afternoon in the next 15 minutes or so is we're going to outline the limitations of the currently available anticoagulants, describe the differential role of Factor XI in thrombosis versus hemostasis, and it's this difference that gives it the potential edge to provide safer anticoagulation, and we'll see how safer anticoagulation could expand the indications for anticoagulation therapy into areas where we haven't gone before, and perhaps in areas we're already into, to provide a better benefit-risk profile. So I don't need to tell this audience that we use anticoagulation therapy to prevent and treat thrombosis. In some cases, we're giving short-term anticoagulation therapy, for example, after surgery or in medically ill patients, to prevent venous thromboembolism. And in other cases, we're giving lifelong anticoagulation, such as for stroke prevention in eligible patients with atrial fibrillation. So we're prescribing anticoagulants all the time, and the problem we have is that despite the availability of anticoagulants, we have the risk of bleeding, and the risk of bleeding can deter patients from taking anticoagulant therapy. You have these green and red cards. So if you're involved in the management of patients requiring anticoagulation therapy, do you feel confident in effectively managing patients who have thromboembolic events despite anticoagulation, or who have bleeding events on anticoagulation therapy? So raise the green card if you agree, and the red card if you disagree. And if you do anything, Jim, I'll say that you shouldn't be treating patients. So please, use the cards. How many of you have had, you disagree, you feel confident, or you don't feel confident? You don't feel confident. And none of us feels confident because we're always faced with challenges. And you had a session earlier today on reversal of anticoagulant therapy, and the fact that we're talking about reversal means that there's a problem. So if we look back at the development of anticoagulation, it's hard to believe that it's 15 years since the introduction of the direct oral anticoagulants, which include dabigatran, which inhibits thrombin, and apixaban and rivaroxaban and edoxaban, which inhibit Factor Xa. And although these agents are more convenient to administer than warfarin or other vitamin K antagonists, and they're safer, particularly safer for the brain, the problem is that we still have bleeding complications, and we have rates of major and clinically relevant non-major bleeding of 10 to 12% in our patients with atrial fibrillation, and this is a problem. And the ultimate goal of anticoagulation therapy is to attenuate thrombosis without disrupting hemostasis, and we're not there yet. So if we look at the anticoagulants we have, whether we've got the parenteral agents, the heparins, the vitamin K antagonists like warfarin, or the DOACs, because they all target clotting enzymes in the common pathway of coagulation, they're going to affect thrombosis, but they're also going to disrupt hemostasis. So we're always going to have potential for bleeding complications. And these limitations, and particularly the risk of bleeding or the fear of bleeding, has led to the systemic underuse of anticoagulation for stroke prevention in patients with atrial fibrillation. The most recent registries in North America suggest that at least 40% of eligible patients are not getting anticoagulant prophylaxis. And when the DOACs are being prescribed, there's an overuse, an inappropriate overuse of the lower dose regimen with the false belief that by lowering the dose, you're going to reduce the risk of bleeding. But you don't reduce the risk of bleeding, but you do reduce the prevention of stroke. So before I start talking about factor 11 and the uncoupling of thrombosis and hemostasis, I want to know in the audience, do you understand how factor 11 could do this, who could uncouple thrombosis and hemostasis? Green for yes, red for no. Okay, so some of you get it, which is great, and some of you, we're going to aim this at you. So remember that hemostasis, or the arrest of bleeding, and thrombosis, an intravascular clot, they both depend on tissue factor as the initiator, and they both depend on the formation of a fibrin clot. But like real estate, it's location, location, location. And hemostasis, or the arrest of bleeding, is predominantly an extravascular event that's aimed at sealing the hole in the vessel due to outside-inside injury. And remember that the blood vessels are surrounded by this hemostatic envelope of tissue factor, and when that envelope is breached and blood is exposed to this large concentration of tissue factor, you get explosive thrombin generation and fibrin formation that makes it unnecessary to have feedback activation of 11 by thrombin to generate more factor 10A and more thrombin. Think about it as a prothrombin. When you have the patient's plasma and you add tissue thromboplastin, tissue factor to induce clotting, the blood clots in 12 seconds. It's 12 seconds because that's the shortest time that thrombin could take to convert fibrinogen to fibrin and your fibrin to polymerize to form a clot. It's different with thrombosis. This is an intravascular event. If an atherosclerotic plaque is disrupted, there's a small amount of tissue factor that gets exposed to the blood, and a clot forms on top of that disruption site, and that clot quickly covers the site of injury to prevent that clot from growing. So what gets the clot to grow? Well, some thrombin is generated. It feeds back, activates factor 11 to generate more 10A and more thrombin, and that causes thrombus growths. So the issue here is that what we're learning is that factor 11 is essential for intravascular thrombi to grow, block the blood flow, and cause the heart attack, the stroke, the DVT. But for hemostasis, because factor 11 is mostly dispensable, it leaves that process alone, and you get that holy grail of attenuation of thrombosis with little disruption of hemostasis. Now, what evidence do we have supporting 11 as a target? Individuals with congenital factor 11 deficiency are protected from thrombosis, and they rarely have spontaneous bleeding. Genetic epidemiology studies tell us that if the factor 11 level is low, there's protection from thrombosis, and if the factor 11 level is high, there's an increased risk of thrombosis. And in animal studies, if you knock out factor 11 or inhibit factor 11 in rodents and in non-human primates, you attenuate thrombosis, but no matter what model you use for bleeding, you don't increase bleeding. So this is different than what we saw when we were developing the low molecular weight heparins, for example, or the DOACs. You increase the risk of those anticoagulants, you get a better antithrombotic effect, but you also got more bleeding. But with these agents, you don't see that bleeding. So how could this work? And this is just one schematic, and what our plan is over time is in the ISTH Academy that will have updated schematics as we refine and improve these things. But you see at the bottom there, that's the hemostatic plug. That's the plug that is aimed at blocking the leakage of blood out of the vessel. And for that, there's explosive thrombin generation so that the feedback amplification loop isn't necessary. But if you have a drug like dabigatran, which inhibits thrombin, or a factor 10A inhibitor like apixaban or rivaroxaban or edoxaban, it's going to have an effect on hemostatic plug formation, just like it's going to have an effect on thrombosis. The difference with factor 11 inhibition is that we have the potential then to attenuate the thrombus growth with leaving the hemostatic plug alone. So the factor 11 inhibitors come in different flavors. We've got antisense oligonucleotides that reduce the hepatic synthesis of factor 11 and in essence create a factor 11 deficiency. We've got antibodies that bind to factor 11, and those antibodies can either block the activation of factor 11, block factor 11A activity, or do both. And we've got small molecules which bind reversibly to the active site of factor 11A, just like the DOACs bind reversibly to the active site of factor 10A or thrombin. So we're back to the same question we started. Have you encountered patients with either anticoagulant resistance or suboptimal response? Of course you have. We all have. And those patients are challenging for us to deal with. So the factor 11, 11A inhibitors are being developed for multiple therapeutic areas, and these are some of the areas. I'm going to show you a chart in a moment that discusses the ongoing phase 3 trials. But in some of these areas, we don't use anticoagulants. For example, secondary stroke prevention in patients with non-cardioembolic stroke. The current standard of care is antiplatelet therapy. Often it's dual antiplatelet therapy for 3 to 4 weeks, followed by single antiplatelet therapy. And for acute coronary syndrome and long-term secondary prevention, unless the patients have atrial fibrillation, we don't use anticoagulants at present. But with a safer anticoagulant platform, we may be able to do better with dual pathway inhibition, where we can target the platelets and target anticoagulation at the coagulation system at the same time. So here, this chart shows where we were in November of last year at the AHA meeting, the phase 3 trials. You can see that these trials are involving more than 75,000 patients. They're trials with abelacimab. This is an antibody that binds to factor 11, blocks its activation by both 12A and thrombin, and also blocks 11A activity. And then we have asundexian and milvexian, which are small molecule factor XIa inhibitors. And abelacimab at a dose of 150 milligrams, it's given subcutaneously. The first dose in the VTE studies is given IV to get rapid 11 inhibition, but for atrial fibrillation, it's given subcutaneously. Subsequent doses, once a month dosing subcutaneously. And it's being tried in the LILAC-TIMI 76 trial in patients with atrial fibrillation who are considered ineligible for anticoagulant therapy. So those are the 40% of patients who we currently are not treating. The two cancer and VTE studies, ASTER is comparing abelacimab with apixaban in patients who are at lower risk for bleeding, and Magnolia is comparing abelacimab with dalteparin, a low molecular weight heparin, in cancer patients who have VTE and are considered at higher risk for bleeding. Asundexian was being investigated in the Oceanic AF study, being compared with apixaban in patients with atrial fibrillation, and being compared with placebo on top of antiplatelet therapy in the Oceanic stroke study. The Oceanic AF study was stopped back last year because of a lack of efficacy of its asundexian compared with apixaban. We haven't seen the data yet, but the data will be released sometimes this year. And the Librexia program is investigating milvexian, and there's an AF study comparing milvexian at a dose of 100 milligrams twice a day versus apixaban. And then there's a stroke study and an ACS study, which are looking at a lower dose because here milvexian is being compared with placebo on top of single or dual antiplatelet therapy. So notice that the dose of asundexian in the Oceanic AF study was 50 milligrams. The dose that's being studied of milvexian in the Librexia AF study is 200 milligrams a day, is a daily dose. So a higher dose. And we're hoping that with the higher dose, we will have efficacy compared with apixaban. So the promise here is that factor XI inhibition will uncouple hemostasis and thrombosis and do better than our currently available anticoagulants, which can't discriminate between those two processes and always have the potential for bleeding. And we think that the potential for bleeding with the factor XI inhibitors will be less. So in summary, the takeaways. Factor XI is a promising target for new anticoagulants that have the potential to be safer than those that we have now. We need these phase 3 studies to really establish the benefit risk of the factor XI inhibitors compared with placebo on top of antiplatelet therapy or compared head-to-head with a DOAC in the case of atrial fibrillation. And I think if we look into the future, I can't see that the factor XI inhibitors are going to take over from the DOACs. The DOACs have been here for 15 years. We have quite a lot of experience with them. They are going generic in many countries. The price is coming down, and they're very effective and safe. But can we do better? Can we do better in our high-risk patients, high risk for bleeding? And can we bring an anticoagulant into spaces like secondary stroke prevention or acute coronary syndrome, where currently we don't use anticoagulants at all? So I'm going to stop there. Thank you for participating. You can evaluate this presentation. I'm going to take some questions.
Are there any specific patient populations that you would be concerned about using factor XI, like for instance, factor XI deficient patients or any other types of patients that might be of concern?
Yeah, I mean, of course, we wouldn't want to use an 11 inhibitor in a 11 deficient patient. And these studies screen patients with an APTT to ensure that we're not treating such patients. But for virtually everyone else, no, I'm not worried about it. Yes, Jim.
So thank you very much for that presentation. It was really, really beautiful and informative. But there are sort of questions about the biology, and you didn't mention the phase 2 studies, which I think, generally speaking, show efficacy in joint replacement without causing bleeding. So already there is differentiation that's been clinically demonstrated. But there's a difference in the sort of the stimulus of the clot between a clot and AF, just as an example, right? Where I think stasis is considered to be the trigger, if you will, for clot formation versus surgical procedure. I'm just wondering if there's a theoretical reason to believe that something might work in, let's say, a surgical challenge, but may not work when stasis is the trigger.
Right. So I'm surprised that you picked on the surgery versus, and AF, because in AF, because of the stasis, the clots tend to be more like a venous clot than an arterial clot. So I think you're right. What the traditional approach to evaluating anticoagulants is to start in orthopedic surgery, because you can efficiently test different doses and determine the rate of VTE. And so you can then begin to associate your whatever biomarker you're going to look at with efficacy. Safety, a little harder to assess because the surgery is getting safer and safer. We're not seeing the bleeding. So you're right in terms of many different agents now, 11 or 11A inhibitors, have been studied in the orthopedic setting, and they've been shown overall to be more effective than enoxaparin for prevention of postoperative VTE and safer. So that gives us a proof of principle. The question is, how can we extrapolate that to other indications? And I think that the clots in AF are also triggered by tissue factor, albeit under a low flow situation, and the clots in something like acute coronary syndrome, different. It's a atherosclerotic plaque rupture, and it's probably the same thing in the secondary stroke prevention trials, because we're picking patients who have strokes in the setting of atherosclerotic disease. So we were able to extrapolate from the venous side to the arterial side with the DOACs. I don't think there's any reason to think that it's going to be different with factor 11 inhibitors. But you're right, time will tell. The good news that we have is that we have safety of factor 11 inhibition over a long period of time. We have that established in the Azalea study, where abelacimab, monthly doses of abelacimab, were compared with rivaroxaban and a better safety profile. So long-term intense factor 11 inhibition was safer than rivaroxaban. And for efficacy, probably the best data we have for efficacy so far come from the Aster and Magnolia study. They're ongoing. If there's anybody who's at high risk for recurrence and at high risk for bleeding, it's the cancer patient with thrombosis. And those studies, we've enrolled more than 500 patients in Aster, getting close in Magnolia, and the DMC has given us the green light all the time. And you can imagine, after Oceanic AF, we're on top of that all the time. So I think, Jim, if there were a problem with efficacy, we probably would have seen it already, but we need to finish the studies. So I take your skepticism. We've been promised a free lunch with other anticoagulants over the years, but I think factor 11 has a good chance of being able to reach that holy grail of giving safer anticoagulation therapy. Other questions? Yes.
Thank you for the great presentation. Do you think there's a role for the use of these factor 11 agents in coronary disease or peripheral vascular disease, where traditionally, antiplatelets are the mainstay?
Yeah, I do, because We have the data from the Atlas trial that low-dose rivaroxaban on top of mostly dual antiplatelet therapy reduced cardiovascular death, but it was associated with more bleeding. So in the short term, dual pathway inhibition with an anticoagulant plus antiplatelet therapy was better than antiplatelet therapy alone. We have data from COMPASS that in patients with more stable coronary artery disease or peripheral artery disease, or even with cerebrovascular disease, with atherosclerotic disease, they benefit from dual pathway inhibition. So the idea of the Librexia ACS study is that the entry point is in the ACS, and it's continued for a long period of time that we're hoping to get the early benefit that we saw in Atlas and the longer-term benefit that we saw in COMPASS in just those sorts of patients.
Thank you. Thank you for the presentation. And my question is, there are a few articles demonstrating that factor 11 may be useful or essential to this cardiac health and cardiac function. And how do we, especially they encounter some sepsis or infection sometimes. My question is how to evaluate the long-term usage of factor 9 inhibitors, such as 5 years or 10 years, when, especially those AF patients, when they encountered inflammation or infection. Thank you.
Well, we don't really have good evidence that factor 11 deficiency makes you more prone to infection. There were some reports. I really don't think that well corroborated, but only time will tell. As 76,000 patients in these studies will have a good database to determine whether we have these problems. Yes.
Thank you for a very nice presentation, educational. There are two mechanisms that sort of bother me. Factor 11 is able to bind to glycoprotein 1b alpha, so taking somehow the platelet into that play. Has this been looked at with these molecules?
I mean, it's a great question. It's not just factor 11. All of the contact factors will bind to platelets. Exactly what they do on the platelet, we're not sure. But if you can inhibit that process, it may be a good thing in terms of thrombosis and not a bad thing. But I don't think we really understand exactly how that process works and how it's regulated on the platelet surface. But I agree with you. I mean, we show that factor 11 binds, but so do other contact factors.
And another question is TAFI. The other question is thrombin activatable fibrinolysis inhibitor, TAFI. So how does these guys interact? Is there any information?
Well, you know, I think in factor 11, if you reduce thrombin generation, then you would reduce TAFI activation, right? So exactly how TAFI plays into it, I don't think we know. But there is no evidence that the patients, you know, with factor 11 deficient patients, we got someone who's an expert, more of an expert than I am there, is that the bleeding doesn't correlate very well with the level of factor 11, as you know, and you have some patients with very low levels who never bleed. You have other patients who bleed. I think there are other pathologies that go on that dictate the bleeding in the factor 11 deficient population, and we're looking at patients who are not factor 11 deficient, although with some of these inhibitors we might be making them pretty factor 11 deficient.
Thank you very much.
Thank you for the presentation. I'm just wondering when can we expect this data from the studies that you mentioned?
Yeah, well, I mean, these studies are recruiting very well, but I think realistically, we're unlikely to see any data this year, and maybe we'll have some data from the cancer studies perhaps next year.
Okay, can I have a question? One more question?
Where's okay.
Okay, thank you for your presentation. My question is very simple. If we can use the ANT11 anticoagulant, do we need the monitor or the factor 11 or not? Because even if as you know, the DOACs currently so many researchers looking for how to monitor or something like that.
Yeah.
Let me know your.
Well, that's a great question. None of the studies is looking at monitoring and adjusting the dose. So they're all being given in fixed dosing. But unlike the DOACs, which have variable effects on routine tests of coagulation, the factor 11 inhibitors prolong the PTT. So if you wanted to know if the agent is on board, the PTT would tell you. But they each affect the PTT differently, so you can't extrapolate from one agent to another based on the PTT and think that if you need this PTT with this agent, all I need is to dose this agent to the same ETT.
Just one
All right.
final question.
Thank you very much for your attention. Okay, you got the last word.
That's last. Do you think we are going to have a trial with mechanical valve or ECMO or whatever?
Yeah, that's, I think what you might want for ECMO might be different than what you might want for a mechanical valve. For ECMO, you'd probably want a parenteral agent, rapid on, rapid off. For a mechanical valve, factor 11 could be a very attractive target because clotting on devices is mediated through the intrinsic pathway with 12 activating factor 11. So there, I think a factor 11 inhibitor could be useful, but they may not all be the same. And maybe what you want there is one that really blocks factor 11A generation as opposed to one that blocks 11A activity. And I'm hoping that we'll have a chance to test some of those in just that sort of indication. Thank you very much.